And thank you to the organization for inviting me in this interesting, very interesting place where nice ideas are applied, really applied. In the first part, I'll present our proposal of clinical algorithm for early diagnosis of CTX. I will fly on the introduction, since Professor Federico, Verrips, and Bonneau did most of the work. So we all know now the clinical and neurological systemic science of cerebrospondylosis xanthomatosis. I will try to put them in order so that we can find a clinical algorithm that we recently proposed. Of course, we know that CTX patients are reported all over the world, as it has been said, and the prevalence is surely underestimated. The clinical phenotype is very heterogeneous, and systemic signs, otherwise neurological symptoms with early or late onset of psychiatric disturbances are present in this disorder. MRI usually shows dentate nuclear abnormalities, and I'll show you our new data on MRI of the cerebellum, which revealed different patterns of cerebellar lesions. I will not refer to the pathogenesis, since Professor Björken will explain very much better than me the pathogenesis of CTX. The background of our work. As we know, quinodeoxycholic acid strongly decreases the synthesis of toxic bile acid. Since the work of Berginer in New England Journal of Medicine in 1984, it has been demonstrated that long-term oral administration of quinodeoxycholic acid stabilizes or sometimes improves clinical and laboratory parameters without toxic side effects. So CDCDA may prevent neurological deterioration, but this occurs if we are able to diagnose early the disease, and we discussed before which may be the instruments, the tools to make this. Now we are proposing, since all authors agree on the need for early diagnosis, but diagnosis is often challenging in the clinical setting, we now propose a simple and practical diagnostic algorithm for early identification of CTX in the clinical setting. The work was structured in 3 phases. In the first phase, we performed a retrospective evaluation of 5 selected CTX series. We carried first a Medline search and selected the CTX series on 3 bases. On the basis of the presence of genetically confirmed diagnosis, on the availability of clinical and laboratory data which could be suitable for our analysis, and the sample size bigger than 10 patients. Then we also evaluated, of course, the clinical data of our CTX population of 55 patients, 28 females and 27 males, belonging to 39 Italian families. In the second phase, we developed the diagnostic tool, and we first built a suspicion index by itemizing the family history characteristics, as well as systemic signs, as well as neurological features. And we gave weighted scores to each parameter on the basis of frequency, peculiarity, which is very important, and also very important, age of presentation of each sign or symptom, as pointed out in our review. So we gave score 100 to very strong diagnostic indicators, score 50 to strong indicators, and score 25 to moderate indicators. All on the basis of our review and on the peculiarity, frequency, and age of manifestations of symptoms. After creating the suspicion index, we built a diagnostic flowchart based on the application of the suspicion index. Then, in the third phase, we retrospectively applied the diagnostic tool to our patient population, and so that the diagnostic algorithm obtained was applied to 55 patients. For each subject, we calculated age and suspicion index at actual diagnosis, as well as the age at which diagnosis diagnosis could have been established by using our suspicion index in order to see if there is a significant difference. Our results. The first phase, the review of selected CTX series, gave us many important issues for discussions. We analyzed 170 patients coming from all over the world. Most of them were from Italy, the Netherlands, Spain, USA and Israel, which are the most important samples of CTX patients. First, we noticed a marked delay in diagnosis, 20-25 years of delay in diagnosis, because patients were first referred to clinicians during childhood or adolescence, at the age of 9 and 19 years, but were diagnosed in the third decade, between age 34 and 38. So there was a very marked delay in diagnosis, and this is the main point. Then, about clinical signs, typical signs of CTX, we observed the tendon xanthomas in 69% of patients, with onset typically in the third decade, as Professor Federico told. Cataract was more frequent than xanthomas and was observed in 88% of patients with an earlier appearance in the second decade. Then chronic diarrhea, another important sign we observed in half patients, but the onset was earlier, was in childhood, with frequent referral to pediatricians for this problem. Then we also observed, particularly in our population, increased incidence of prolonged unexplained neonatal cholestatic jaundice, and this was another important point. Neurological symptoms. Spastic paraparesis and ataxia were very frequent. 77% of patients had spastic paraparesis, while 62% had ataxia. But they presented later than the other, at the end of third decade or in the fourth decade. Then more than half patients had mild or moderate intellectual disability since scholar age. And psychiatric disturbances was also observed in 50% in half patients, with onset in the third decade. The presence of polyneuropathy, as detected by EMG and often subclinical, was observed in 2/3 of patients, but the diagnosis was in the third or fourth decade, as well as dentate nuclei abnormalities, which were observed in 75% of MRIs of patients, but they were diagnosed in the third decade. Notably, all untreated patients we reviewed who underwent serum cholesterol assessment showed elevated levels of serum cholesterol, and this is very important in order to assess our screening tool. This table represents all the data we screened in the 5 populations, so I will not explain more, which I already said. And this box plot represents the age at onset of each clinical indicator. As you can notice, diarrhea and intellectual disability, as well as epilepsy and cataract, presented in the first or second decade, while tendon xanthomas, for example, presented in the third decade, as I told, as well as neurological motor impairment. In the second phase, we built the suspicion index, and we gave a score to each of these indicators on the basis, as I told, on frequency, but not only of frequency, also on the peculiarity of the symptom and of the age at onset. So we collected family history indicators, systemic indicators, and neurological indicators. We considered as very strong indicator, we score 100, the presence of a sibling with CTX, being obviously a recessive, but an autosomal recessive pathology, and the presence of tendon xanthomas, which are very peculiar of the disease. Then we consider strong indicators, the presence of consanguineous parents, as well as of juvenile cataract, which was very frequent, as I told you, but can be observed, we know, in many other pediatric disorders. And we gave a strong score of 50 points also to chronic diarrhea and prolonged neonatal jaundice. Then, among neurological characteristics, we gave score 50. We gave score 50 to ataxia or spastic paraparesis. This means then that the presence of both is 50, score 50 and not 100. So we can we have to divide it. The presence of dentate nuclei alterations at MRI was also considered a strong indicator with score 50, as well as the presence of intellectual disability and or psychiatric disturbances with score 50. Then we gave a moderate score, a score 25, to early osteoporosis, epilepsy, Parkinsonism, and polyneuropathy, which are less frequent and notably are also present in many other diseases and not peculiar of CTX. So we built a diagnostic flowchart on the basis of the application of our suspicion index. A score of 100 warrants serum cholesterol assessment. As I told you, serum cholesterol assessment in all patients, we know, revealed in all untreated patients, obviously, in untreated patients including statins, including steroids, including other bile acids, so they have to be untreated. Serum cholesterol assessment shows elevated values in all patients. So if elevated cholesterol values are found, this is the easier thing to do. We have to do CYP27A1 gene analysis, confirm or exclude the diagnosis. In absence of cholesterol elevation, we provided another point. In presence of an affected sibling, so in presence of an high risk to develop the disease, an higher genetic, an higher statistic risk to develop the disease, we think that it's worth to perform genetic analysis also in absence of high cholesterol levels. Then we also stated that a suspicion index of 200 with at least one very strong or four strong indicators warrants both serum cholesterol assessment and genetic analysis, in order not to miss patients with typical clinical characteristics in spite of cholesterol assessment. Then we applied this diagnostic tool to our CTX patient population. What we found: age at diagnosis, actual diagnosis, was 35 years, and suspicion index at diagnosis was very high, was 300, a mean of 300 at diagnosis. So also we observed the serum cholesterol elevation in all patients with values of at least tenfold elevated against control, and most importantly, the age at suspicion index 100 was 10 years, the median age, and the age at suspicion index 200 was 24 years. So the difference between age, as you can see here in the box plot, between age at actual diagnosis and age at which suspicion index reached 100 was 25 years. In this table, you can see with the black arrows the most frequent diagnostic indicators, which were xanthomas, cataract, and spasticity. Importantly, some of these, such as spasticity and xanthomas, were not very important to assess an early diagnosis, because they were very frequent at the diagnosis, but they were present in few patients, as you can see, at suspicion index 100. On the contrary, diarrhea, for example, and cataract also, and intellectual disability were frequent also at suspicion index 100, and this means that these were very important. These signs, these indicators were very important to assess an early diagnosis. So, I repeat another time that early diagnosis and timely introduction of replacement therapy are considered, all of us consider it crucial in CTX patients. And our review, however, pointed out a marked delay between symptoms onset and diagnosis. We also know that once neurological disability is established, the efficacy of treatment is more limited. And the recent study that Professor Verrips showed, evaluating the long-term neurological disability of CTX patients, revealed that subjects who started therapy after the age of 25 had a worse neurological outcome. And also in the patients followed by Verrips, there is a similar age, a cutoff age. So our results show that the present suspicion index could allow an early diagnosis of CTX with possible diagnosis also in the pediatric age, so that treatment can be started before a neurological disability occurs. Later we'll discuss if a pediatric screening program may be also needed, with maybe assessment of serum cholesterol in children with cholestatic jaundice, in children with cataract, in children with unexplained chronic diarrhea. But what I want to tell you is that our suspicion index is very easy to apply, and you can apply it in the clinical setting, and most of the diagnostic indicators can be determined from medical history, for simple medical history and clinical examination. So we propose the use of our clinical suspicion index in clinical practice, and we hope for further validation in your patients. This is the work we published a year ago on the suspicion index on Journal of Inherited Metabolic Diseases, and you can read it in order to have all the complete data on our suspicion index. Then in the next part, in the second part of my presentation, I will show you some data I collected with Professor Dotti, who couldn't be here today, on cannabidiol on CDCA treatment in our patients. What we know about CDCA in CTX treatment is that oral replacement therapy with bile acids decrease the production of toxic intermediates by inhibiting CYP7A1, which is the key enzyme for bile acid synthesis in the classic pathway. CDCA is considered unanimously the strongest inhibitor of this enzyme, and as I told you, long-term CDCA intake normalizes bile acid synthesis, leading to disappearance of abnormal metabolism from serum, bile, and urines, and a clinical stabilization. Also, I will show you that CDCA improves neurophysiological parameters and bone mineral density. However, we have patients with neurological progression. This is the point, most important, but despite a biochemically effective CDCA treatment. We have reported, and the Spanish colleagues have reported them. Replacement therapy with other bile acids, Professor Federico told about it, has been attempted. Ursodeoxycholic acid failed to reduce cholesterol plasma levels, while cholic acid was proved to be biochemically effective. However, despite CA has been proposed as an alternative to CDCA, we think that further studies are required to assess its biochemical and clinical efficacy. In this study, we showed the clinical relevance of of spasticity in cerebrodentinous xanthomatosis, and we observed an important improvement of motor evoked potentials obtained by TMS in patients with early diagnosis. So we demonstrated that CDCA therapy is able to improve the conduction among corticospinal tracts, often subclinically, but also is able to stabilize the pyramidal signs of the patients. Among electrophysiological studies, one recent study is on polyneuropathy, which is very frequent in cerebrodentinous xanthomatosis. We observed a great response to treatment with CDCA in 20 patients who underwent CDCA treatment. CDCA did not influence the number of axons activated by the electrical stimulation, but increased the conduction velocity of all the still excitable fibers, and this means that CDCA therapy promotes myelin synthesis in the fibers with residual unaffected axons. And this effect may depend on the extent of irreversible structural damage to axons, and this makes early diagnosis and treatment crucial again. Then we also studied bone mineral density recently in CTX patients, and we observed an improvement, a marked improvement of all the bone mineral densities, and also of volumetric bone mineral densities, which are normalized values for age and weight, and are very important. And we observed also an increase of serum 25 vitamin D. So we demonstrated that CDCA treatment increases bone mineral content independently of the age of patients. And this is maybe due to bile acid restoration with improved intestinal absorption of vitamin D, but maybe other pathogenetic mechanisms should be investigated. However, I told you that we have patients that are not responsive, not well responsive to CDCA treatment. For example, in this case we published a week ago, we observed the presence of enlarging brain xanthomas in a patient with cerebrodentinous xanthomatosis with worsening phenotype. And the other case, the other important case we described was a patient with progressive cerebellar vacuolation, as you can see, with a worsening of cerebellar score, despite biochemically effective therapy on both cholestanol and 7-alpha-hydroxycholesterol, 7-alpha-4C, okay, which is the cholestanol precursor, considered very, very important for neurological disability. So we are observing, and these are unpublished data, we observed the MRI characteristics of CTX patients and analyzed 37 CTX patients. We were surprised to find 4 different MRI patterns involving the dentate nuclei. The first was the classical pattern, which was the presence of T2 weighted and flyer hyperintensities suggesting cholesterol accumulation. But we also observe other patterns, such as T1 weighted and flyer hypointensities consistent with vacuolation due to a neuroaxonal loss, like this we observed in this case report. Then we also observed the presence of T1 weighted and flyer and susceptibly weighted hypointensities consistent with calcifications, as confirmed by cranial tomography. Then we also observed the absence of signal alterations of the dentate nucleus. So 4 different patterns. This was important because a long-term follow-up showed the progression from the pattern 1, the classical pattern, towards pattern 2 and or 3 in some rapidly progressive cases. On the other hand, the evidence of the same MRI pattern over time was usually associated with a stable disease. So we think that clinical and neuroradiologists should be aware of these distinct patterns which may reflect different stages of the disease, but can also be observed independently. And according to our preliminary data, we have to confirm them. The replacement of flare repair intensities with hypointense areas consistent with vacuolation or calcification could be a marker of disease progression. So this could be a very important neurological marker of poor response to therapy. Also, the presence of vacuolation and calcification at onset is, in our opinion, another important negative prognostic marker. We are also performing and writing a long-term biochemical evaluation here in 19 patients. I show you the preliminary data on all the group of patients, showing a marked decrease till normalization in a long term of more than 4 years follow-up of cholesterol, and also a decrease of 7-alpha-C4, which remains tenfold higher, however, in our patients. As expected, 27-hydroxycholesterol was practically absent or very low, and cholesterol, total cholesterol, and this is another important point to clarify, was normal in almost all patients. We divided the neurologically stable patients from the neurologically worsening patients in order to see if different biochemical patterns can be observed. Actually, we did not observe significant changes, significant difference between the two groups. The only difference, but these were not significant, statistically significant, were the levels of cholesterol and 7-alpha-C4 at baseline, which were a bit higher in patients with then progressed with respect to the stable patient. This could be a point to study. And importantly, we also observed the presence of a more important neurological disability as assessed by a DSS and ranking score at diagnosis in patients who were neurologically worsening. And so it may mean that the presence of neurological disability at onset, at diagnosis and at treatment start may be also a negative prognostic factor. So, in conclusion, our experience on CDCA therapy, I divide all the aspects. From a clinical point of view, we can affirm that 2/3 of patients showed clinical stability during treatment. Even at a long-term follow-up, we have patients with 25-30 years of follow-up, while 1/3 of patients showed a clinical progression despite treatment. We know that motor, cognitive, and psychiatric disturbances are the major causes of disability in these patients. From a biochemical point of view, cholesterol metabolism, we observed that CDCA restored serum levels of cholesterol till normalization and 7-alpha-C4 from 200-fold increase to 10-fold increase. So the 7-alpha-C4 did not normalize completely. And this by inhibiting CYP7A1 enzyme in the classic pathway, while as expected, serum levels of 27-hydroxycholesterol are not influenced by CDCA therapy. And we did not find, as I told you, statistically relevant differences between stable and worsening patients. From electrophysiological parameters improved, both the conduction parameters of the corticospinal tract and those of the peripheral nervous system. Bone mineral density is also increased by CDCA therapy, which decreases the risk of bone fractures. This is very important, as you know. Regarding brain MRI, I repeat that the presence or the development of vacuolation or calcification of the cerebellar dentate nuclei seems to be a negative prognostic factor, and we are further analyzing this aspect in our big group of patients. And Then some points for the discussion: the possible causes of the disease progressions despite treatment. First, the delay of a diagnosis and treatment, with maybe a longer exposure to toxic metabolites. Then the presence of a neurological impairment at diagnosis, as I told you. We have, for example, as Professor Federico showed you, in a patient, we